In the last segment, we addressed the question of whether neuromuscular difficulties were likely to be the causal factor in speech sound disorders. A related question about the strength argument is whether we should believe that non-speech oral motor treatment would be expected to result in increases in articulator strength. As Clark points out, when we consider the research on muscle physiology, there are certain characteristics of exercises that would be expected to increase the strength of the muscles being exercised. These include that the exercise should work a muscle group to the point of fatigue before you would expect that there would be a significant strengthening effect. One question that's therefore asked is whether a specific non-speech oral motor exercise is employed to the point of genuine muscle fatigue. In the majority of cases, non-speech oral motor exercises are stopped before they reach this point, and therefore the likelihood that such exercises would lead to strengthened muscles is low. So one thing to consider is that although this question has not really been tested empirically in children with speech sound disorders, we have a substantial theoretical basis to suspect that it's unlikely. In addition, the empirical research we do have suggests that strength is not unusual among children with speech sound disorders, and so the benefit of strengthening articulators, even if possible, would be debatable. And finally, while there's some evidence that certain types of stretching exercises can increase tone in certain muscle groups, Clark points out that this benefit is likely to be limited to the muscle groups that exhibit a certain type of stretch reflex. Among the articulators, only the muscles that close the jaw display this reflex. Therefore, the use of such stretch exercises in order to increase underlying tone among muscle groups outside of the muscles that close the jaw should be predicted to be ineffective. The limited studies that have shown some increase in neuromuscular tone have not shown any benefit to articulatory skill. The final rationale for non-speech oral motor treatment is based on the notion of developmental hierarchies. It's proposed by some that speech movements develop out of earlier developing non-speech movements, including sucking, chewing, and oral motor reflexes. The implication of these arguments is that if a child has difficulty performing one of these earlier developing oral motor skills, then they'll also have difficulty with the articulatory movements that depend on non-speech movement patterns being solidly in place. However, work by Chris Moore and Jordan Green, among others, has shown that there is a notable lack of continuity between early non-speech movements and later speech movements, despite the fact that these two movement types share muscle groups. It turns out that the neurological pathways that control speech movements are organized in a fundamentally different way than the neurological pathways for non-speech tasks are. And as might be expected, the muscle activation patterns that are triggered by these differing neurological activation patterns also differ. Although the muscles themselves might be shared between speech and non-speech oral tasks, the activation patterns themselves are different. The implication of this research is that developing new non-speech oral motor skills might be a fine thing for some clients, but we should not expect that gains in non-speech tasks would have automatic benefits in speech motor tasks. In the final segment of this presentation, we'll look at treatment efficacy research with a brief review of the literature relating to both non-speech and speech-based treatment programs.